Solution Talk. Investing in health, securing futures. Advancing universal health coverage. Please welcome onto the stage Serah Makka from TheONE campaign.
Thank you. Indeed, this is what it is, a solutions talk. So what we want to do is not admire the problem. We know that, yes, there are about half the population of the world lack access to essential health services. And yes, we know that for many low-income and middle-income countries, 40% of health financing comes from out-of-pocket. A country like Nigeria, 75% of health funding comes from out-of-pocket. We also know that the WHO says we need about $371 billion every year by 2030 to achieve universal health coverage. So we know the context and we know the challenges. And we're not daunted by them. So what we want to do with this conversation is move it closer to solutions. So what do we do? And as the title says, investing in health, securing futures, advancing universal health coverage. I've been introduced. My name is Serah Makka. I'm the Africa Executive Director for TheONE campaign. And this session is brought to you by BMZ, in collaboration with BMZ, the Federal Ministry of Economic Cooperation and Development. To kick us off, it's my pleasure to introduce to us Dr. Bärbel Kofler. She's the Parliamentary Secretary, State Secretary for the Federal Ministry of Economic Cooperation and Development. And she is a staunch health advocate to ensure Germany's investments in global health initiatives. Please give her a round of applause.
Makka, thank you very much for this kind introduction and distinguished guests, honorable speakers, and I get a mic. Otherwise, my voice, I think, is loud enough. I'm from Bavaria, you know, I know how in the beer halls, how to speak there. No, it's really a great pleasure and a great honor for me on behalf of BMZ and also TheONE campaign to welcome you here to this important session, and I like very much what you were pointing out right in the beginning. It's about solution talks. So don't expect the solutions from me now, because I'm only doing the introductory part. But we all know we are coming here together because health is of utmost importance to all of us in all countries around the globe. We just had a session where we were wondering and being puzzled a little bit why 3 years after the pandemic was coming to an end, we are sitting like and doing and acting like we've done before the pandemic. Yeah. So we might doubt sometimes how much we learn out of those situations, but we are here to come up with positive ideas and positive solutions. So I'm very happy to have also colleagues, ministers from Malawi, South Africa, the World Bank, Global Fund here, and have you all here. Of course, also the youth counselors, because I think that's very important to have the next generation also here on the table. Once again, welcoming you. So we should not miss this opportunity after having learned something from the pandemic to really come up with all the experience around the globe and pull it together and see what could be done to better health systems. And I'm always talking about systems. We did it today also. That might be typical German, we always think, because we have a long-standing experience with health systems and securities. And yes, every country has its own experience, but at the end of the day, it's about really creating access to everybody who is in need of medication, of vaccination around the globe, especially also to the most vulnerable people. So if we take that into consideration, we know we need strong security, social security, health security systems. How to come to that? That's the challenging momentum and that's challenging questions. One thing is, and I don't want to overstress ODA and that part, but I think it's important to use it wisely to invest into systematic changes and systematic building up of institutions. And that's something which I want to assure you from the German side here in that momentum. We are sticking to those topics. We are sticking to health. That's an important topic for my ministry for decades, and we will stick to that topic because it is that we want, especially in those challenging times, being also a reliable partner around the globe. That's important for us.
That's good.
Doesn't matter. On the other hand, just coming back, for example, from the African Development Bank annual meeting last week, I heard the call of many African countries to say, oh, we have to do something on our own. We want to lift up our domestic resources to be able to decide what are the points which are important for us from our point of view. So that's also something I think where our economic cooperation can really give a good input to strengthen I think Kofi Annan was saying that once, the administrative muscles to really come up with an efficient, for example, tax revenue system, which then can be give the money, the resources to invest in global public goods, in health sector, education, and other things decided by the countries on their own. Well, we know times are challenging. I don't go to all the crises, geopolitical shifts, physical constraints, and all those things. You know them better than I do sometimes. But what we really have to do is coming together in a positive sense and see how we come first to concrete actions. That's what Hamburg Sustainability Conference makes it different. We want to be concrete. We want to come into actions. That might not be the 100% solution to everything in one paper, but at the end of the day, if there are certain commitments we all go for and we all agreeing on, I think we can get a step further. Second, for me, it's important that we also share thoughts that really how to prioritize health services. I think that's really a big momentum to prioritize those institutions and to see how that could make a difference on the ground then. And the third important point I was already pointing out, it has to be coverage for everybody, especially for the most vulnerable ones. So it's not an exclusive thing where you have to earn a lot of money and then you be part of an insurance type of system. So it's about being exclusive, and I use the old-fashioned term, living solidarity. I think that's the important thing inside societies and between societies. So that's a call of action, like you were also saying, pointing out, and I think as one of the last sessions on this Hamburg Sustainability Conference, we should use really this momentum to call to action on that important topic. I thank you very much that you're so much interested, so much engaged in that. And I wish you all a very fruitful discussion. If I sneak out in maybe 20 minutes, don't blame me. It's just because I have to go to Berlin. I have an appointment tomorrow morning, so I hope that's okay with all of you. But I wish you very fruitful discussions, very fruitful talks, and thanks for being here and sharing your knowledge with all of us. Thank you.
Thank you very much, Cabinet Secretary Kofler. I think raising the point around the sustainability of healthcare, raising the point around action, raising the point around coverage for everyone is the reason we're here. And we're actually set up in a fishbowl. You'll see that there's a center, but we're all part of the conversation. And we'll ask folks who are sitting by the door, please walk in and enter into the external of the fishbowl as we have this conversation. I'll say two things before we get started. You'll see a green flag somewhere where you're seated. And if you don't have one, we'll have a stack somewhere around. This is for engagement. If there's a conversation, there's a comment being made that really resonates with you, just wave your green flag on. We want to see if there's connection with the topics. Exactly, that's the spirit. We're also really excited to have two people in the room here. We have a graphic recorder, which means she'll be capturing everything that's being said, the salient pieces, in graphical form. So let's just say hello to Susanna back there. Susanna, can we just see you say hello? That's right. And we have Lara Müller, who will also be having a live scribing throughout the session. So we're covered. Now let's get to the business of the day. Domestic health resources. Honorable Chimpeni, and before I start with you, maybe I should give a sense of my panel here. We have Honorable Noah Chimpeni, is the Deputy Minister for Health for Malawi. And we've got Dr. Githinji Gitahi, who's the CEO of Amref Health Africa, the largest community-based organization on the continent of Africa. We have Mr. Aki Nishio, the Vice President of the Development Finance and a lead for IDA, which is the concessional fund that was raised earlier. And we've got John Fairhurst. And John is the Head of Private Sector Engagement at the Global Fund for AIDS, TB, Malaria. So this conversation is complete. And I have to say, we have a young advocate who's in the room. Aubrey's here. She'll join us shortly to also have her intervention. We wanted to mix the domestic African landscape with the multilateral landscape, with the private sector engagement, mixed with community-based conversations with our young people, and the rest of you to have a really robust conversation. I'll start with you, Honorable Chimpeni. Okay. So Malawi is demonstrating some commitment to healthcare, but can you tell us in concrete terms what Malawi is doing to increase domestic resources for health?
Okay. Oh, thank you very much, and thank you very much for having me here in this room. For us in Malawi, investing in health is not just a sectoral priority, it's a strategic investment in our people, our economy, and our future. Universal health coverage is central to our vision of building a resilient, inclusive, and productive nation. We see health not only as a human right, but also as a foundation for prosperity and stability. Let me share you a story about Malawi. The issue about health and health financing is very emotive and political. It started in 1964. During our first president, who was trained in America at Mehari College of Medicine, he again trained in Scotland. He went to Ghana, set up his practice. Then he was called back home to lead the people. So when he came, the first thing, if you've heard about cabinet crisis in Malawi, it was about health. He was advocating for people that they should be paying something in hospitals. While those he found back home were not for that idea. He said, no, people, it should be free health for all. So fee was introduced in hospitals. Then the numbers going to hospitals dropped. So him and others thought that maybe people now have stopped falling sick, yet knowing that people were not able to afford we're not able to afford the £1 which was supposed to be paying in hospitals. I was a member of the health committee of our parliament. We went around asking people what would they want to see, a better health service whereby they would be paying something in hospitals or free medication for all. So the people in the villages were advocating for that. Maybe they should be paying something, because currently what happens most of the times, when they go to a hospital, to a health facility, they would be given a prescription whereby the health facility does not have the medication. They end up going to a pharmacy where they would pay more than if they were given medicine, if they were paying something in hospitals. Or sometimes they even go to traditional healers where they pay exorbitantly rather than paying something in hospitals. But because it's an emotive issue, we as politicians, we shy away from advocating for that, because you know what happens if you do something which is not in tune with the people and the voters that put you in power. At the next election, you're booted out. So as a country, what we're doing, despite our resource level being small, we have tried to make sure we have increased the funding to health, not necessarily to the level of the Abuja declaration, which calls for 15% of your national budget, but we have tried, we have moved, trying to make it to increase in the health funding. We have also institutionalized annual health financing dialogues between the Minister of Health and the Minister of Finance, platforms that foster joint accountability and evidence-based planning. These engagements are helping reposition health as a driver of economic growth, not merely as a cost center. We are also exploring the innovative financing. For example, we are assessing the feasibility of introducing a health tax, such as levies on tobacco, alcohol, and potentially mobile airtime to increase additional space. All these we're just trying. Additionally, we're restructuring the health service fund to put to domestic, external revenues in a more transparent and efficient manner. We're also encouraging hospital autonomy, especially in our central hospitals, where we're saying that we usually when they go there, it's congested. For my example, myself, I may not go to a public hospital. Now that maybe I'm a deputy minister, I can go. But when I was just when I'm just a salaried employee, I wouldn't go to a public health facility. I would go to a private one. So what we're saying is, the central hospitals, at least, they should introduce some paying wards whereby those maybe who are in a hurry would want a very faster service. They should be able to pay something. So those resources will be pulled back into the facility. For example, in most of our facilities, even in the villages these days, if you go there, you find that people want, for example, if they've lost their beloved one, sometimes even at home, they would want to go to a health facility, access fund services that are paying, like embalming, for example. Just because maybe they want to wait somebody, a son, maybe who's in South Africa, maybe in England, they would still pay for those services. So that's why we're saying, look, why don't you expand these services so that at least hospitals should be able to make money whereby they would be using the same money they would plow back to the facility. And also what we're doing as a country, we believe that prevention is the smartest investment. In our country, we're expanding network of our health surveillance assistants. These are the trusted community workers who are in every village, delivering services ranging from immunization to family planning and health education. These HSCs are the backbone of our health system. We are strengthening their supervision, equipping them digitally, and creating pathways for professional development to enhance quality and retention. At the national level, we are also rolling out health promotion campaigns that target both communicable and non-communicable diseases while integrating water, sanitation, hygiene, nutrition, and adolescent health in primary care platforms. Again, for the youth, what we're doing, well, we've introduced youth, because our population is 60% of our citizens are the youth under 25 years of age. This can be our greatest asset or a missed opportunity, depending on the investments that we make today. We're scaling up youth-friendly services, including integrated sexual and reproductive health and HIV services. We are also investing in life skills, comprehensive sexuality education, and economic empowerment pathways for the young people. I think for now, let me stop there.
That's excellent. Thank you, Honorable Chimpeni, for just laying that out. Health taxes, tobacco, annual conversations on health accountability with the Ministry of Finance, really important. Prevention as a smart investment. I wanted to pass it over to you, Aki. IDA raised 100 billion this year for the IDA replenishment. I would love to hear how IDA, as that concessional funding, which many African countries require right now, how that supports domestic resource mobilization within country.
Great. And first of all, thank you very much for having me here. And I'd like to start with IDA. And as Serah knows well, IDA is the world's largest fund for the poorest countries. And in the last replenishment, we managed to mobilize $100 billion. And that was based on a $24 billion of contribution from donors, but which got multiplied by 4 because we are able to leverage at the market. Now, IDA, and Serah will remember, in my native Japanese language, it means this is love. And one of the ways with which IDA imparts love is through the universal health coverage. And this is something that's very high in the minds of the IDA community members. And how we actually do this is we have a country-based model. So we have allocations for each country, and they decide what their priorities are. But increasingly, I think health has become a bigger priority, higher priority. So what we do is we finance projects. Mostly, I think the projects that are most relevant to universal health care is these health system strengthening projects. We have 160 of them in implementation around the world. And that's IDA and IVRD, so it's a lot of projects. And in the IDA side of things, we make policy commitments each time we do a replenishment. These are promises that we make to donors that we will get certain things done. And for instance, in IDA 19, we had about 45 of these policy commitments, which included one to help countries prepare pandemic preparedness plans. You know, so there are always some firm commitment that we make on the health front, so that we sort of inch towards universal health care. And also, IDA, the bulk of IDA is used for public sector investments, and 70% goes to Africa. But we also have a $3 billion allocation for private sector window, and this de-risks the private sector from making investments in poor countries. And we have had a number of health projects, hospitals and clinics. So that's another way with which we provide funding for health. So all in all, I think these are the things that we have been doing. But I'd like to stress the fact that I think in order to reach universal health care, it has to be done through partnerships. And well, IDA itself is a partnership of 61 donors and 78 borrowing countries. And I think every effort we make should be done in partnership with others. And let me end by saying that at the end of this calendar year, there will be a universal health coverage hub to be established in Tokyo with the World Bank, WHO, and the Japanese government. And I think that's a very good step towards knowledge sharing and moving together on this agenda.
Thank you, Aki. And I know Aki has to leave in about 10 minutes or so, or at the half-hour mark to catch a plane.
Yeah,
so
right.
stay with us as long as you can. But if you stand up and move, we know why. Dr. Githinji, I want to come to you. We heard Honorable Chimpeni talk about tobacco taxes, the ways they're trying to raise funds. We heard Aki talk about the private sector window, $3 billion for health as a country-based model. How do we ensure in all of this we don't leave the poorest in our communities behind? What do you have to say to countries as they think through domestic resource mobilization? How do we make sure it's inclusive?
Allow me to probably paint the picture by revisiting what Honorable Minister said and what we know of the available fiscal space for health in the countries in Africa. Then I can answer your question, because your question is around social protection. And social protection first needs to understand who is in, who is out, the social protection. And the whole UHC is also about what's in, what's out, who is in, what's out, who is out, that kind of dimensioning. Malawi, where my brother comes from, has a population of about 24 million, 25. I'm sure censuses are done more than 10 years apart, so you're not sure. And the fertility rate is high, so it's different. Right. But let's use the World Bank numbers and say it's about 25. The GDP, the nominal GDP for Malawi is about 14 billion. Okay, so when you look at those numbers, and we say apply a rate of tax to GDP ratio similar to OECD countries, because I think we hear a lot that African governments need to tax more, and they do. They must tax more. And it's difficult, because it's more difficult to tax my baba than it is to tax me, because I'm employed, yeah? So the average is 15%, but let's assume it's 34%, which is similar to OECD. Now take 34% of Malawi's 14 billion, okay? Then allocate 15% of that to health, which is Abuja. So he has a government, and the government has responded to everything we are saying. Raise taxes, 34% from their current 18, allocate 15. You will end up with $24 per capita for health per year. That's the thing that we don't pay enough attention to. Germany is $5,000 for the same calculation. And the figure for Malawi is exaggerated, because they'll never raise 34% of tax from the GDP. World Bank says, 18, you're doing very well. So even if you do 18, which they're doing, they're actually not doing very badly. So their actual allocation right now, which is lower than Abuja, is about $13, $14. Even if they raised it and go to 24, it will not be earth-shattering. It will be important, it's good, and must be done, but it will not be earth-shattering. Therefore, then the question comes in, then what do they do? Which is now back to your question, because they will never achieve $4,000. They'll never achieve 5,000. The projections of World Bank with the current economic growth is many countries will achieve $100, $99 by 2100 for health, based on these statistics I'm giving you. So we have to rethink the entire health system. We can't be focused on Abuja. 15% of an elephant is different from 50% of a chicken. So if our focus of health advocacy and health financing is on Abuja, we will never get it right for our continent. And we have to be alive to these numbers. So what do we do?
Can somebody de-mic me?
So, am I demiked? Can you hear me?
Yes.
Okay. So what do we do then to your question?
Yeah.
It is about health. First, there is, of course, partnerships, which is what the Organized Development Assistance has been doing. Almost 50% or so of Malawi's health budget was financed through these partnerships, which is now at risk. A lot of the balance is from households that have to decide whether to buy food or go for healthcare. So that's what we want to eliminate. So if you work to those numbers, then you say that you have to redesign your health system. Even as you increase money from $13 to $24 per capita, you have to get more health for the dollar. And getting more health for the dollar means asking yourself, whose money are you counting? Because more of these numbers we're giving and counted by World Bank are actually allocations, budget allocations to the Ministry of Health. What is the money for water doing? What is the money for sanitation doing? And what's the money for agriculture doing? So as we discuss, and I know we are moving forward, I know the German government and others are leading a convention on financing for health. It is time to start rethinking what really is health financing. Because if health financing is what's given to the Ministry of Health, the Minister of Health should have a certain level of control or leverage on the water budget, on sanitation budget. Because then we are not counting healthcare budgets. What we are now talking about are healthcare budgets. When we talk about health budgets, and health budgets are about breastfeeding. Health budgets are about clean water for everybody in Malawi. Health are about sanitation. If you did clean sanitation and water in my country, in Malawi, in Chad, wherever, you'll eliminate diarrhea and pneumonia, which are the leading killers in our continent. It's not cardiac arrests. It is actually things we can solve outside the health ministry budget. So we need to rethink that framework, and we need to redesign the health system to be reflective of health production, not healthcare consumption. So I think that's a key dynamic now. When you do this, then you ask yourself, how do you then protect the most vulnerable? Because you don't have money for everything for everybody. We have to redesign also, and I'm sad that Japan has left, because Japan has been a big force in UHC. In my own view, we need to redesign or to define UHC, because UHC says universal health coverage. What's universal? Our governments, our politicians understand universal to be 100% of my population. With $24, you'll never achieve it. But if you say you is 100% of the vulnerable, so you start to have a conversation about saying our population that's most vulnerable is X. Therefore, we must achieve UHC by making sure that 100% of the vulnerable are covered for all the primary healthcare needs that they have. The rich can struggle. They'll keep moving on. They'll go to private sector, as the Honorable Minister was saying. So we have to redefine the social protection agenda within UHC, not just equity, but social protection is a critical principle within UHC. The final point is that we must forestall future costs. We cannot afford the cliff that's coming on us for NCDs. We can't. Most of these budgets we are talking about, $13, $14, are going to infectious diseases. Yeah. Non-communicable diseases are being funded out of pocket. But what is fastest rising? It's NCDs, it's cancer, it's hypertension, it's diabetes. Okay? If everybody in Malawi was to be rich, diarrhea, pneumonia, TB would disappear. We wouldn't have to do anything about it. Okay? But NCDs are rising, but we are doing nothing. If you look at the continent of Africa now, and you look at transfat regulation, industrial transfats, which come from fast food and all these things and fried foods, where are they coming from? The fast food industry is coming from the higher income countries. When they leave the high income countries, I'll not mention any country, they have regulations on how much trans fats is allowed. They have regulations on front of pack labeling. When they come to Africa, those regulations don't exist. And because they don't exist, they go the cheapest route. So they use the cheapest oil and they provide the food different from the regulations from their source countries. But our government must invest in regulating trans fats, regulating sugary beverages, alcohol, and those. And out of that will be a source for taxes to improve your health. But most importantly, will save us the cost for tomorrow, which we can't afford and will not afford. So I want to stop there, because it's a very complex issue. And all these principles are the ones that I think needs to underlie
Dr.
financing
Githinji,
for.
I have to say that as you were speaking, flags are going up.
Yeah.
There's a call you've given for redefining what we calculate as health.
Yeah.
So Honorable Chimpeni is here with a health budget, but there's water, there's agriculture, food is medicine.
Yeah.
But how we calculate that on a global front is important. Welcome. There's also something to be said for how we define universal health coverage. And if we're having a movement, it has to come from the continent of Africa for, yes, the global definition of this, but what impacts us, what is customized for us must be this because of our trajectory. And also future-proofing. We can't have the same model that, say, a Germany has or a US has for Malawi or for Nigeria, for Kenya. We must think of a different model for what healthcare looks like. So I think there's some salient points coming out of this. John, I'd love to turn to you. I think one of the things that Dr. Githinji came up with is the innovative way we need to look at it. And I know the Global Fund for HIV, TB, and Malaria is in the middle of a replenishment. You have raised about, if my math is correct, about 90 billion since your inception, and you're the private sector engagement sort of lead. So how are you seeing the Global Fund redesigning the model to incorporate ensuring that Africa leads on domestic resource mobilization? The moment that we're in is so vastly different from the previous moments that I think there's a forcing function for innovation anyway, but would love to hear your thoughts around domestic resource mobilization and the partnership it requires.
Yeah, well, thank you. It's always hard to follow Dr. Githinji in that conversation, but I will try. I think the moment we stand before, as Dr. Githinji, the Honourable Minister, said, is a challenging one. And I think it speaks to, I think, reinforcing the things that we need and historically have done well. But I think it also needs to adapt to a different context that you see before us. So maybe to start with some of the first things, I think one of the core principles of the Global Fund has always been that the country needs to drive the agenda. We have to put the country, the ministry, and it's important, I think, to represent that health in a country is made up of both the government services, the private sector, and the communities that we serve. And one of the ways that the Global Fund has always done this is to make sure that our funding is designed by that collective. It's designed by a cross-sectoral collective, which is very much in support of the government agenda. But it makes sure that the perspectives of the most vulnerable, the perspectives of the government services, and the role of the private sector, which is so key, I think, in many countries in providing health to people, is engaged. And it means that our grants are designed to fit into and align with the government agenda to I guess, to add to the GDP that is there. And that, I think, does a number of things. One is it builds a design of a program which is locally owned, locally relevant. Two is we all want greater domestic financing. That's the path that we want to take countries on. But it is a path. We have to move countries along. We have to make investments that allow countries to get there. It's not a switch that we can turn on. And I think Dr. Githinji made that case really powerfully. So the way that international institutions invest in countries to build the capabilities to get to a largest part of domestic financing is important. And if you don't have ownership, if you're not investing with the Ministry of Health, with the country at the centre, then I don't think you can get to sustainability to that investment. So I think that's really key. I think the second theme is also about health systems. As an organisation that's focused on HIV, TB, malaria, one of the things that's very central to us is that eliminating diseases that are very central, very core, very hugely impactful on health system resources has to be about building a functional health system, has to be investing in community health workers, in laboratory systems, in supply chains that are not just for those diseases. They are for a functional health system that can work on things, including NCDs, as they become a bigger part of the agenda. We spend about $2 billion a year in health systems. We're the biggest multilateral financer of systems globally. It's really important for us that builds a system that is multifunctional, that also, as we saw during the pandemic, is able to respond to new threats at the same time. So I think building systems as opposed to vertical interventions is really central. I think the third piece, and I think this is really relevant to the context that we face, is working together. And the colleague from the World Bank said this. I think it's really central that we optimize the efficiency of financing for countries. We align the financing more effectively with countries. And we leverage the different capabilities of institutions like the World Bank and the Global Fund and Gavi and other institutions. To do that, that means working together. We're working significantly with Gavi to align our financing in health systems across countries, including Malawi. And we've also done a number of alternative finance. I don't like the word innovative finance particularly, but alternative financing structures that really leverage and align different sorts of financing. So we've done, and actually Germany has been one of the central leaders in this, debt swaps. And debt swaps for health allow countries to take existing debt payments and repurpose them to invest in health systems. And I think that has a huge impact in terms of repurposing health for financing for impact, but also reducing.
Green flags are going up.
It's a critical and
favorite topic.
We've done something like $300 million of that investment, and most of it has gone towards health system strengthening as well. So it's really powerful. The second thing is in bringing innovation forward, and I think as we move forward in the context, one of the counterintuitive parts of a reducing financing context is you have to accelerate innovation. You have to bring the best practice solutions to countries faster and to communities and to people faster, to the most vulnerable faster. And so in this period, I think we need to accelerate the things. We have some things like long-acting injectables for HIV, which will be transformative, potentially end HIV as a public health threat. And if you think about the financial burden that could be reduced for ministries of health, for countries, for communities, it's huge. So really, doubling down on the investment in innovation is really key.
Excellent.
And the last thing on partnership, and then I'll stop, is about working with partners like the World Bank. We've done around 12 transactions in countries actually across the world, but significantly in Africa too, that leverage our capability and the World Bank's capability, and leverage something like $1 billion of finance for countries to really reinforce their access to longer term and bigger levels of funding as well. So I think as we can build on the things that we know well and migrate to make sure that all of us are following those kind of principles, I think we will do a better service to the countries and the communities that need us.
Excellent. I really appreciate the fact that it's a path, not a switch, and all the concrete examples of solutions you gave. Audience, I'm going to turn it to you in a minute, so I'm going to ask you for your solutions. But before we do that...
Before you do that, can I just come in with a little something?
Sure.
Okay. Yeah, because when you talk about investing in health, as Malawi, we continue to invest. But one of the investment we're doing, which is having minimal impact, is because we invest in our human capacity. We train nurses, medical doctors almost every year. Government invests in that. But by the end of the year, government is not able to employ these people. These people are given loans, which they would repay once they get employed. But yet government is not able to employ them. So to me, that's why I'm saying that is a wasted investment. There was a time when we used to say that you cannot go work elsewhere because you have been trained by the government. But now we've realized, we've removed that barrier because we know that we cannot employ these people. Therefore, let's open up, because that's where it would be like investing in the economy. Once you invest in the economy, if our economy grows, it means some of these the issues we're talking about will be...
Can also grow.
Because in Africa, in Malawi in particular, we live extended family. Once my mother trained me, I know even I'm sitting here, if she falls sick back home, I would be able to send money for if she is got hypertension, she would be able to afford the hypertension medication because she's got a son who she trained, who is now employed, would be able to afford. So imagine all these people who have trained their sons and daughters to go to school, hoping that they would help them. The government has invested in them. The government is not able to absorb and employ them.
So there's that spillover effect of investment. One of the things we know is that Germany actually works with Kenya for nurses. Yeah. Rwanda actually invested with Ethiopia to train their doctors. So there's some models of investing in healthcare that could work, even though I hear you say you can't hire them, but there's a role for Malawi perhaps to train and deploy them elsewhere to places that need.
Yes.
Before we go, I do want to get our youth.
Recently, just to tell you that recently, these are about the health assistance we're talking about. We're having interviews as I speak. We want to employ with the assistance from our donor partners. We want to employ 2,700. But what happened? 100,000 turned up for the interviews, filling stadiums for the position of 2,700. I can even show you.
Yes, no, and there's a role for that because there's a thirst for capacity building. And I do think that health as a driver of economic deepening in Africa is a place we've not tapped into that we need to have a conversation on. I wanted to bring Audrey in because we've had conversations here with the private sector elements, with governments, with our civil society, the young people. Audrey, you've heard this conversation. Tell me, is it resonating with you? Where you sit, what else do you think we can be thinking about and doing?
Thank you so much for your question. First of all, if I could, I would like to introduce myself once again. My name is Audrey Boateng, and I am here as a One Youth Ambassador. And we represent a network of young people across Europe and Africa that stand for global justice, as well as global health, the topic that we are talking about today. And my message today is quite simple. I've heard the numbers, I've heard the structures, the systems, and one thing that I'm really, really burdened by is the involvement of affected younger people. We speak about these things a lot, and I'm very, very honored, by the way, to be here today because I believe that I'm representing not just one today, but I'm here representing millions of young people that don't have the chance to be here today and to express their needs and their burdens. So the message I have for decision makers, for leaders today is let us become more aware of the needs of the younger people and involve them when it comes to decision making. I'm here today as a young voice to speak to you, but it shouldn't end here. There are people out there, brothers and sisters of me back home, that can't be here today and can't express their needs and their struggles with you today, which is why me sitting here with you today is a big statement because I have the luxury to pick up my card, to go to the doctor, to be checked, to receive medications, but millions of young people don't have that luxury that I can enjoy today because I was born and raised in Germany. So I have these accesses. So I'm just bringing this to you that we can't talk about future without now including the younger generation, even domestically. There is an urgency for these people to sit at the table with decision makers, with leaders, because they are the ones that have to shape their own futures. They are the ones that will decide the next steps for tomorrow. So my message here, as I said, is very, very simple. I'm just here to bring this before you to make sure that all these numbers, all these structures that were mentioned are very good, very helpful, very insightful. However, very, very important, let us be more aware of the needs of the younger ones and include them in processes like this, include them in conversations. We don't want to be just at the table, but we want to build the table with you. So I'm just here very, very burdened and passionate about this, that when I leave this place, it doesn't just end with my voice being heard, but millions of other young people having the opportunity to sit at the table with decision makers and shape their own future.
Excellent.
Thank you very
Powerfully
much.
said, Audrey. Thank you very much for that. And I saw a lot of green flags go up. We have about 1 minute left. Solutions. I have a hand here and a hand here. Yes.
I just want to thank you very much also for all your very good instruments, which are very needed, definitely, but I think it's an emergency situation at the moment. And I just looking at you, it's a global fund. I'm just looking because, and I agree that non-communicable diseases must be treated also in near future, but at the moment there will be a high crisis, and I just wanted to make a call really to have a look on an emergency plan for HIV/AIDS, malaria and tuberculosis in East African countries. And I think that's the elephant here in the room. And just for that one, I would like to mention it. And I also would like to mention that the USAID cuts, the most affected sectors have been HIV/AIDS, malaria, tuberculosis and SRHR. Means also STI prevention, etc., etc. So please have a look really on the priorities, which are needed in strengthening health systems.
Excellent.
Thank you.
Priorities. Another solution back there. There's the mic. If you can just grab the mic. Yes. Excellent.
Okay, thank you so much for the opportunity. I'm John Kino Cheng, UNICEF, the advocate with disability from Kenya. Yeah, so I'm happy with my fellow young person is there, and she has talked very well. And it's very true. And I can see the Deputy Prime Minister here. You talk about the population for young people in Africa is about 60%. And it's very true, you need to give us an ear, not just propaganda. I'm so sorry to say that. You need to act out because the future is on our hands. So my question is, because I said I'm a youth advocate with disability, now mine is relating disability on health. So my question are, how can we ensure that healthcare for universal health coverage are inclusive for persons with disability? You understand the challenges that are affecting us as persons with disability, maybe in terms of inaccessibility, communication barrier to hearing impaired and others. Maybe the last question is, what innovation strategies can you adopt to mobilize domestic resources, specifically for disability inclusive health services in resources constrained in setting? Thank you.
Thank you very much. We are over time, so there are two things what I'm going to do. One statement closing from our panelists. Seville is next. We need actions to take to the next conversation, so we're not just talking. One statement, and in that statement, if you can answer any questions that were raised, please do that. Ambitious, but we must. One more thing, and then we will project to you what the notes we've taken from this conversation. Suzanne will do that right as we leave. Let me start with you, John. One statement, closing, and any kind of responses you can get.
Well, I absolutely agree that youth is central. Building particularly, I think, young women's voices and the future of health is central to where we go. I think for me the statement is that there is a challenge and a crisis that we have to deal with. We have to build the opportunity that sits there, the efficiency between organisations, the investments we make, making the most of innovations that really drive change. I think those opportunities are what we need to focus our energy on.
Thank you. That was either a really long statement or several statements. I'll go to you, Dr. Githinji. One statement. Sorry. One statement.
We need to integrate inclusivity and inclusion from the training of health workforce. Sign language, all those things need to start from when I go to medical school or nursing school.
Excellent.
Secondly, that investments in women and girls' reproductive health is the best investment any government can make, because it is part of forestalling future costs of maternal health and safe abortions and allowing girls to go to school.
Excellent. Those two comments, two statements. Honorable Chimpeni, you have the last chance to make it one statement takeaway.
One statement, first of all, to answer something on what he said, is we're aware as a government that we have got people who are physically challenged, so we're making sure that all our facilities, even those which are built way back, whereby they're difficult to access by a person who is maybe using a wheelchair, we're making sure that they're user-friendly to people with disabilities. And again, we realize that our future lies in the youth. But again, in schools, we introduce sexual education, for example. But then we're hampered with sometimes traditionals who would not want to discuss sexualities in a school. So that's another fight that we have to take on as a country, because otherwise all our efforts will be put to waste if we know that somewhere the church tells you something else, the government is telling you another, and your people in the village are telling you something else, and the government is telling you another thing. So there we need to find, those are the issues that we
Excellent. Suzanne has been taking notes. Suzanne out there, can you just project the draft illustrative graphic notes that you have? Please see what our amazing Suzanne has performed. There will be a final version of www.one.org once she cleans this up and makes it prettier. It's really amazing right now. So please stay tuned for that. This is a Solutions Talk. Thank you very much for coming with your solutions and the ideas. I hope you have a great rest of your day. Thank you.
Thank you.